And we're very excited to be talking about such an important topic today, which is the new approvals of T-DXd in both in the neoadjuvant and adjuvant setting. So we've moved away from anticipation now to action. And so these are sort of the topics that we all want to hear about, which is how are we using T-DXd and what are the most common barriers that you think community oncologists are going to be faced with in thinking about T-DXd in general?
So thankfully, we're very familiar with T-DXd from the metastatic setting. You know, it's like pretty much every patient gets T-DXd at some point in their metastatic journey. So we're very comfortable with it. But now we, with our new FDA labels for stage 2-3 breast cancer, HER2-positive breast cancer for the preoperative use of 4 cycles of T-DXd followed by THP, and then from the DB05, the broad label of any residual disease, we really have good leeway to think about bringing that in. And our stage 2-3 patients, probably by and large, will get T-DXd. I think that's really the nuance is going to be for the lower risk T2N0, you know, for example, because in DB11 it was T3N0 was the eligibility criteria, but this is a broader label of stage 2-3. So we have some leeway there. But the good thing is if we decide for a lower risk individual to just go with a classic TCHP or more rarely an ACTHP, we can always bring in the T-DXd if they have residual disease, you know, after surgery. So I don't see it so much as barriers. It's just, I think, it's going to take us as a community, I think, a little bit of time to see whether is it going to be kind of like anybody who's eligible, both in terms of comorbidities and other, you know, their overall health, and also eligible for receiving it per the labels. Are we going to give it to everybody up front? And I'm just curious, what do you think?
Right. So I think that for my node positives, I'm clearly going to be using this strategy. I'm impressed by the PCR data, particularly for the ER positive group. But you bring a good point, which is we see a lot of T2N0s, at least in our communities. I treat a lot of young women in my practice, and they're doing their screenings, they're coming in, and those may be strategies or patients for which I might do a modified approach, where I might think through switching the approach instead of starting with T-DXd, or another group of patients that are elderly patients who I'm concerned about their toxicity profile. Can they even handle chemotherapy at all? Mm-hmm. Is this a group where we might do an adaptive strategy, where you might do taxane, HP, followed by imaging, reassess, and then give them their T-DXd? Obviously, that is not the way the study was done. But in my node positive, clinically node positive and larger clinically T3 tumors, I'll be doing as the study did, which is starting with T-DXd up front.